I went into medicine to develop relationships and to help people create hope and healing. And, I felt like interventional was great for acute pain, but my true passion was more with chronic pain.
3, 2, 1. Liftoff.
Welcome back to the Ketamine Startup Podcast. I'm Kim Ko, and this is where we talk about building a ketamine therapy practice, industry insights, and what's shaping the future of psychedelic medicine. Today, we have a conversation that challenges everything you think you know about chronic pain treatment. Sam is joined by Dr. Michelle Weiner, who went from high-volume interventional procedures to comprehensive integrative pain management that treats the whole person. Dr. Weiner is double board certified in Interventional Pain Medicine and Physical Medicine and Rehab, and is a member of Florida's Medical Cannabis Advisory Committee. She operates multiple locations across South Florida. Her practice represents a new model that combines conventional treatments with cannabis and ketamine protocols, as well as working with a multidisciplinary team of coaches and therapists. You'll hear how she reframes fibromyalgia as central sensitization, why she incorporates the spiritual dimension in her biopsychosocial model, and how she empowers patients to address the root cause of both physical and emotional pain for lasting relief. Before we jump in, though, a quick reminder. The information shared in this episode is for educational purposes only and does not constitute medical or legal advice. Treatment approaches discussed should be evaluated with your specific practice context and regulatory environment. Now let's dive into this conversation.
I am super excited to have Dr. Michelle Weiner on today. She and I met years ago in person, and now I get to finally interview her. So it's an honor to have you here, Michelle. Thank you so much for joining us.
Thank you for having me. It's an honor to be with you right now. Thank you.
Tell us about your background a bit and the pathway. Specifically, let's say starting in college, med school, residency, fellowship. Let's get back to the beginning and tell us a little bit about your journey to what you're doing.
Sure. So I've always actually been very athletic and very into nutrition. And even in undergrad, I was a nutritional science major, health science education minor. So I wanted to educate about the body. And I developed a lot of interest in physical medicine and rehab. And I wanted to initially be a physical therapist. And then I started to work with a physical medicine and rehab doctor. And I realized that being a doctor, I would be able to do many different things as opposed to just a physical therapist, which I thought, was more interested in the physical body. And then I realized over time how much of the rehabilitation is necessary for long-term change. So I went to medical school. I also did my master's in public health. I wanted to do research as well. And I went into physical medicine and rehab at University of Miami. And then I loved to do procedures. So I did interventional pain through anesthesia also at University of Miami. And what happened was I realized that we had great tools for acute pain, like epidural injections and different pharmaceuticals, but that chronic pain was very misunderstood. And I really became more fascinated with the population, like fibromyalgia, chronic migraines, neuropathic pain, where there seemed to be another component that we were missing that was related more to the person's subjective experience of pain that wasn't always related to their physical body. And so I started to research more about integrative options for chronic pain. And I learned about medical cannabis, and I saw how cannabis could be one tool to help someone either with pain, sleep, anxiety, with their mood. But, I realized it was more of a medication that was taken daily or more often and was more of like a crutch. And I wanted to see if I can go a little deeper and understand what the root of people's pain may be so that I could then unravel that and unfold it and help them feel certain things. And it led me to learn more about ketamine-assisted psychotherapy because in my training, I learned about ketamine infusions for pain. But through my psychiatry friends, I learned how to do it with the assisted psychotherapy. So I opened my own practice. It's an integrative pain practice. We treat both mental health and physical pain. And I really am interested in the overlap between the two, where one's physical pain may initiate some type of change that happens in the brain that then can be processed and treated in a different way than just by acute pain options.
Yeah, that's remarkable. I really feel like you were on the cutting edge in a way about, both the physical side and components as well as the emotional and mental components and bridging those two together. What did your colleagues in pain medicine think or give feedback when you first were like, "You know what? I'm actually going to do something a bit non-traditional." In a way, I mean, because classically, when I see people who are board certified in pain medicine, they will, do, a lot of the interventional stuff, whether it's
Right.
epidurals or radio frequency ablation or neuromodulation or spinal cord stimulation. But in a way, you took a different route. So what was the
Yeah.
feedback that you got from them?
Well, it's interesting because I was chief resident, chief fellow. I loved to do procedures. I was very interventional. And I just developed this love for the chronic pain, specifically fibromyalgia population, which was so unheard of for any pain doctor. For the most part, that was the most challenging patient where we didn't have great options. And I felt like we were not being honest with them.
Mm.
Like for me to keep prescribing a medication, changing the dose, adding another one, trying a different injection, using a different medication in that injection, that really wasn't going to help them. And I felt like we were stringing these patients along and the chronification of their pain was actually creating more of a problem for them. So I felt like we had to get to a point where we could either look at them from a different lens and not specifically, "Oh, your MRI shows that you have a disc herniation or you have knee osteoarthritis and that's the source of your pain," but realize that over time when they have these repetitive noxious stimuli, it is actually creating this neuroplastic change. And the change that then happens is in the central nervous system and not in the physical body anymore. And we see that, the pain doesn't just stay in one area, it spreads over time. The receptive field changes, the way that the threshold for the activation of these different neurotransmitters change. And so, my colleagues were I was in an interventional practice for many years and I was doing that and I wanted to slowly go into something else and what I had to do was actually justify what I was about to do, which was difficult because interventional procedures, as we know, may financially do better than some of the other options. And also it's covered by insurance. So you have, more volume, let's say. But in my heart, I had to do what I was passionate about. And I think that was like a big shift that happened where I was able to say, I'm comfortable and confident knowing that this is the patient population for me. And I wanted to develop relationships with the patients and truly help them heal. And I felt like medicine was just becoming, a place just to do procedures and use pharmaceuticals and not really get to know what's at the root of one's pain. And that kind of shifted when I was able to say, I went into medicine to develop relationships and to help people create hope and healing. And, I felt like interventional was great for acute pain, but my true passion was more with chronic pain.
Thank you for sharing that. Was there a specific moment or a patient? Because what I'm hearing is it sounds like you were really leading with your heart. You were going with your passion. So I'm curious, was there a specific moment, a patient maybe, when you were like, you know what, I'm going to take this leap and do and open up my private practice?
Yeah, I think that day after day of going into a procedure room and seeing someone lie down, face down and just getting ready to do an epidural injection without really communicating with the patient and seeing their face, I felt like I lost a lot of my ability to properly treat that person because I wasn't able to really be with them to experience their overall feeling in life and how did they perceive the pain and what was really going on in their psychosocial aspects of their life was missing. And so like day after day of just doing procedures over and over, I got kind of frustrated. And I think it was actually learning more about cannabis and the ability to alter one's consciousness that allowed me to open my mind a little bit and see this person is now having this open conversation with me. I started them on cannabis. I wanted to deprescribe their opioids. Now they're telling me I'm taking less opioids, but I'm also having other experiences that I never had before where I'm able to connect with myself and my family, and I'm sleeping better, and because of my sleep, I'm able to do more functional things and move my body and stop avoiding things because I'm in pain. And I think actually by treating patients using medical cannabis opened the conversation because they felt they could trust me, that I wasn't just there to do something that was going to either profit me or maybe not help them. And then they were able to be open with me and express that this new medicine that was a plant that was illegal for so long is now changing their life by opening their mind and helping them create meaning. And I felt like a lot of them were more open, even the older population, they were more open to trying something new because things haven't been working or they're just repeating the same thing over and over. And then they lose hope and they lose faith in the medical field.
Yeah, and I noticed that, I'm in California state, you're in
Right.
Florida. So is cannabis legal or can doctors prescribe that? What's going on with the laws and,
Yeah,
the
so we
statutes?
have only a medical cannabis program. We don't have recreational or adult use. So you guys have had it for like 30 years. I think it was in 2018 that we started to use medical cannabis. I was the chair of our advisory committee through the Department of Agriculture. I started to learn a lot about it and teach a lot of other physicians really how to dose patients properly, how to use different routes of administration, how not to smoke or vape, but to be open-minded to other forms. And I think that led me into the personalization of pain management and understanding that we're treating the whole person and each person is individual based on, for example, their endocannabinoid system. And the way that the THC affects you may be very different from somebody else. And that kind of opened my mind to say, so there's not just one medicine or one procedure for a diagnosis. We actually have to treat the person with the diagnosis, not the diagnosis.
Which is much harder to do. It's
But it's really how you effectively treat someone because, otherwise, if you just look at their imaging or a list of whatever diagnosis they have, and you're just gonna use a cookie cutter type of plan, that may not work for everyone, and also, you're not really getting to know that person and what their goals are, and I think that's really why I started to treat more chronic pain because I was interested in why what would work for someone versus somebody else and why someone was going to adhere to a treatment plan and versus some and also I think it was a little bit of um me allowing them to feel safe with me and not to feel like I was in charge of them, but it was a relationship, like I feel like a lot of doctors have an ego and they come across in a this is what how we treat this condition and I'm more into all pain can change. So, you have pain now, it can definitely shift whether it's emotional or physical, and I'm just here to help guide you, to give you the resources, to show you different options and really, sometimes someone's physical pain changes because of a psychosocial aspect. They fall in love, they, change a belief that they have about themselves. And so sometimes it's not always what we're doing to the body, but more the mind and the brain.
Yeah, I love that because you bring a biopsychosocial approach to your care. And for me, I'm also along that same paradigm because I went to medical school at University of Rochester, and that is where Dr. George Engel, who is a psychiatrist, he invented the term and concept of biopsychosocial model of medicine. So, how did you get into I call it BPS, biopsychosocial. How did you get into that model or approach or paradigm of medicine?
Well, I think I learned more about neuroscience, and I think I started to educate my patients even about the neuroscience of pain and how even though these signals are ascending from the body into the spine up to the brain, there's different pathways. There's like the lateral pain pathway that tells you where the pain is and how intense it is, and move your hand away. And then there's the medial pathway that's more related to suffering and how it relates to your behavior. And so when we have these different pathways that are overactive, then we end up having patients that have different experiences of pain. And so if their alarm is going off all the time, their signals are going to be more intense. If they're stuck in this thought about my pain defines me and really starts to become who they are, then they start to avoid different things. And I realize if I can educate them about pain and they realize how many components are involved, it's not just, the physical body, but it's these signals that go up. It's the way that the brain interprets it, and then the descending pathways that are also trying to put the brakes on. Then we realize, well, we can adjust one part and that could shift something else. The psychosocial aspect to me, was more, why is the person suffering? Is that related to the fact that they're not able to do something that they once were able to do? Do they have fear? Do they have shame? Is it that they have a belief that they're not good enough, that they don't belong? And can those beliefs be shifted and then actually affect the way that their brain is interpreting these signals? And so I realized how much of one's pain perception is not just how severe the problem is in the body, but how that alarm is going off over and over, and the lens that they're looking at the world seems like a threat to them. And so if I can decrease that threat, if I could kind of calm the nervous system down, which sometimes requires safety, support, connection, tools. So what tools can I use to affect change? It doesn't always have to be a medicine or a procedure. Sometimes it's like we were talking about, a partnership, right? Like it could be something very simple that shifts that then, and that's what I've seen with patients over time is they fall in love and then all of a sudden their pain is less, or they, sleep better and then they start to see the world from a more organized perspective. So I think that we look at physical pain in more of an acute management way. When the pain becomes chronic, we have to see what are the psychosocial aspects that we can shift that then could decrease the signals in the nervous system so that the person can actually look at the world from a perspective of safety.
That's so fascinating. Have you seen any common themes with your patients with chronic pain and suffering specifically? And I'm just curious about the fibromyalgia aspect. Or have you seen any similar themes, whether it's adverse childhood experiences, whether it's PTSD, whether it's sleep or relationship? Like what are some of the things that you're like, yeah, I'm kind of noticing this occurring more commonly in this specific subset of patients?
Yeah, well, I think what you're getting at is taking a really good history to understand when the injury or trauma started that primed the nervous system for this hyperreactivity. And so if I'm not able to get that, the injury, the trauma, whatever started that, it's difficult for me to understand why it led to a chronic pain situation, but there's usually something. And a lot of times it's the person not admitting to that. So often, there was some type of physical trauma that happened. They were in a car accident and then all of a sudden they had neck pain, but the neck pain also created depression because they weren't able to do a hobby that they love to do. And, that's kind of the regular spiral. Or they had trauma as a young child and the adverse childhood events led them to this hypersensitivity within their nervous system. And now they're in this hypervigilant state, looking at the world like it's a dangerous place to be. So there's usually something that can tie into it when that started. The important thing is for the person to realize that, because if they realize that that trauma is tied to the fact that their pain has become chronic, then they're able to understand the relationship. If they don't see that relationship, it takes a little bit of time to unfold it, to explain to them, why is your nervous system so reactive right now? So I think the getting a really good history, which is also why you can't just treat pain, in a 15-minute follow-up session, because or a new patient you can't just see in 15 minutes, because you really try to understand who they were before the pain and what their goals are and how things have changed over time. And it's like we talk about the hyperactive default mode. I'm always interested, what's your story? What's the narrative that you're telling people? What's the language you're using in your head to describe yourself? What are the different narratives that are limiting you that are then contributing to the nervous system being in a different state that's not able to calm the pain signals down.
Yeah, and let's rewind for a moment because when the average clinician hears the term fibromyalgia, they may kind of blow it off or think it's some sort of I don't know, made up diagnosis. So tell us, like, how do you diagnose fibromyalgia? What are your clinical criteria or historical criteria?
Yeah. So I call it central sensitization. I don't even use the term fibromyalgia. I just don't, because I feel like even giving someone the diagnosis of fibromyalgia keeps them stuck, because you're telling them they have fibromyalgia, they're going to go online and look up what that is. Then they're going to try to figure out what's the best medication or treatment for them. And what happens if they've tried all those meds or the meds have different side effects? We don't have good FDA approved options for fibromyalgia. So I'm not going to lead them down that path that's just going to create hopelessness. So I call it central sensitization, and I just explain how one incident or trauma can ignite this neuroplastic change, and now it becomes centrally mediated, and we're not actually treating the physical body anymore, but we're trying to create more certainty for the brain, because the brain likes to know what's about to happen, and what's how to predict what's about to happen. And so when they're in this state where they don't know, is this going to make my pain worse, or am I going to do something that's going to aggravate my fatigue, my cognition, my depression, whatever it is. So, usually I don't use the term fibromyalgia, but I talk about central sensitization a lot. I explain what that is, and I explain how the treatment is really to try to get in touch with your feelings and try to be able to feel safe within your body. And until they can create that relationship, it's difficult to just use a medication and assume that's going to take care of it. And I do get that the fibromyalgia medications, they work on these descending inhibitory pathways, serotonin, norepinephrine. Also interesting to think about how we're treating physical pain with antidepressants. So obviously there's some overlap there. But, I usually try to focus less on the body and more on quality of life and their function. So what are you not doing because you have pain? What are the things that you used to do, and how can we get you back to doing those? And less on, more imaging. And when you see someone's in that state where, it's like it's a you're attuning to the patient. The patient feels heavy, they feel depressed, or they feel hyper and anxious. You want to understand who they are and what their nervous system feels like, so that then you can help treat them and kind of shift what's going on. So, I would say I don't love to use the term fibromyalgia, because I feel that the patient ends up feeling hopeless after they get that diagnosis. And it's better to use something like central sensitization and explain how physical pain can become more centrally mediated.
Yeah, and I really love that because when someone gets a label,
Yeah.
that in a way impacts their trajectory, just having the label of fibromyalgia. Now it's in their medical charts and other, clinicians will see that, and it just, I don't know, it
It's like
can.
disempowering, right? It's like disempowering, like what we want to do the opposite. We want to give them the strength to then make their own shift. And that's why also with ketamine assisted therapy, it's not just ketamine, it's the adjunct therapies that go around with it, because we're not just trying to give you a medication to fix you. We're trying to give you a medication that's a tool or a catalyst to make a shift that then you're going to go a little bit deeper and change some of your psychosocial aspects to your life that then can create long-term change.
I want to extend the biopsychosocial, and I'm going to add in one more. This is one of the ways that I've thought about biopsychosocial, and I've added a term. So I call it the biopsychosocial spiritual component, because I do believe there is a spiritual aspect. So I would love to hear your thoughts if you add in that spiritual component, or whether that's just outside of the realm of neuroscience. So we're not going to go there. But what are your thoughts on the spiritual aspect of suffering and trauma and pain?
I also agree biopsychosocial spiritual should be what we call it. And I believe that the spiritual component can create this awe-like effect. And something like awe, where it's something that you've never experienced before, it's new to the brain. It allows you to start to make a belief that other things are possible. And I think that people resist, they get stuck in certain states that feel comfortable, even though they're not really healthy. And I think that the spiritual component is such an important one because it's the relationship that person has with themselves and how they connect to other aspects of the world, nature, a type of God or something bigger than themselves. And I think that when we're so focused on us and internally thinking about ourselves, we lose the fact that we are part of a bigger whole. And if we can kind of like open up our mind to realize that each of the things that we do affects other people, it affects nature, it affects communities. And if we can be part of something bigger, then we feel connected, which is a positive feeling. But also, there's a lot of science behind spirituality. And I think that's what's really interesting is that we can understand that even neuroscience has some like there's a book called The Awakened Brain by Lisa Miller. It's a great book and it's all about the science of spirituality. And so even the people who don't want to go there because they think it's too woo woo, well, if you use something like ketamine, you can explain it in all different ways from the mechanism and the plasticity, but it's the person's own experience. Why did they see this kaleidoscope type of picture? Why did they, go back to a moment in their time when they were young again or free flowing, flying in the sky? That was their own subconscious imagination. So like to not grab onto that spiritual component is just a lost opportunity. So I love the fact that you're bringing up that fact that it's biopsychosocial spiritual. And I think that it's important to be connected to others. We can't be isolated. We should have a belief that there's something bigger than us that, we're not just in charge of everything. I think that it's important to think that way.
Yeah, I had a friend of mine this past weekend. He's a physician, he specializes in family medicine, but he gave me a really good question to ponder. And so I guess he was talking with one of the hospital chaplains and he was observing the chaplain. And one of the questions that the chaplain would ask the patient is, how is your spirit doing? And I was like, that's a really good question to ask. Let's say someone's admitted or, they're suffering for XYZ reasons. And then the chaplain comes in and asks this question, how's the spirit? How's your spirit? And I really appreciated that. And it may be something I incorporate into my practice. It's quite direct. And, but yeah, I think that it can be a powerful tool. And I love what you're saying about the science behind it as well, because I am also a scientist as well.
Well, and also, the spirit, everybody can use their own word, but it's, the essence of who you truly are. You were brought into this world as a soul. You can believe whatever you want to believe, but that soul is specific to you. It has your essence, your true nature. If you want to heal, you probably have to get in touch with that soul or spirit in order to make a good connection to figure out what's the best path for you. And I think, that's really important is not to rely on people outside of you to tell you what's right for you. If you're disconnected from your body, if you're disconnected from your spirit, you're not able to make these decisions. And I think a lot of people are overactively in their head, not having these embodied experiences, which doesn't allow for that mind-body connection. And so I think bringing in spirit and soul allows the person to realize the intensity of having that relationship with yourself and also realizing you're one unique individual. This is your spirit. How do you want to portray that in this lifetime? And I think that the spirit could be brought into medicine more, through things like ketamine assisted therapy and psychedelics and having these moments.
One of the things I've noticed is that people and physicians and clinicians in this space who are willing to get into that spiritual aspect have had a personal spiritual experience. So if you feel comfortable with sharing, is there any moment you can recall that you're like, yeah, that was a pretty spiritual experience for yourself, Michelle?
Well, I'll tell you, when I was trained at the Ketamine Training Center by Phil Wolfson and Bessel van der Kolk and Gita Vade, we went to the Catskills and I was trained um, for ketamine assisted therapy, but it was didactics, but it was also we had to take the medicine. So we did an intramuscular dose and we did a lozenge. And we also learned how to sit for other people. And so I have experienced ketamine. I think it's important too. I think that a lot of times the patients ask, have you experienced this? Because they want to know that they feel comfortable with you, that you know what you're doing. And I did have a unbelievable experience where I was with my kids on a merry-go-round. And it was at a time that was kind of challenging in my life, and the main focus and the main insight I gained from that experience was the most important thing is love. And I was with them on this merry-go-round, and I remember like almost like seeing heart emojis, like just hearts everywhere. And I said to myself, the meaning of life is love, just to give and receive love. And it was such a simple moment, and it was actually such a low dose of ketamine, and it was such a simple, but such an intense feeling that, it was sort of like, is there anything else that I don't know beside, like, it was so overwhelming to understand that love is really just the source of everything. And no matter how I go through life, as long as I'm giving and receiving love, that's really, my mission. That's how people should be walking through life. The interesting thing is I relived that experience later on, and that to me was unbelievable. So I had a ketamine experience, and then a few years later, I was actually at like in a merry-go-round with my kids, and it was very specific to that experience, what they were wearing, and I actually relived something that I had already experienced during ketamine. To me, that was just unbelievable to understand. Yeah, to try to understand how years back through ketamine I saw something, and then years later I actually physically lived it. And I was with someone. I said, "Remember my ketamine experience? This is what it was," and it was so clear to me. But it was just amazing how the brain can create an experience, and then I lived it later on. So I have had these all like moments where it makes me think there's something bigger than just us walking through life making these decisions. And that is exciting to me because it makes me think that there's more. And I think that it's more than just the brain and the body, but like the spirit and nature. And I think all of that is very important into someone's overall health.
Yeah, thank you for sharing that vulnerable, authentic, personal experience. As you were describing that, I got kind of shivers down my spine, and then the other part of me, the funny part was thinking about Matrix, and it's like, yeah, that's a glitch in the Matrix, where
Right.
where had that experience and then physically had the real experience. That's really powerful.
And then sometimes you don't wanna even, um, have an answer for how it happened, like, I think that's interesting too, because people always wanna know, "What's the mechanism of this?" and "Why do you think this came up during this session?" And sometimes we don't really know, but how do you feel about that? And sometimes it's just actually an experience or an emotion that then just opens your mind and says, "Wow, that really did happen, and I have learned something from it, and at the same time, I don't need to understand all of it."
Yeah, just sitting with the unknown, like, we don't have to know everything, although, we do like to know, but maybe there's just some mysteries in life that we won't understand.
Hey, listeners, this is Kim, and I just want to acknowledge that you're here for a reason. Maybe you're stuck in a cycle of long shifts, feeling a little burnt out, and wondering if there's any other way to practice medicine, especially on your own terms. We've been there, and that's exactly why we created this free checklist, your step-by-step roadmap to starting a ketamine clinic without those costly mistakes. Grab your copy now at www.ketaminestartup.com/checklist. It's completely free because we want you to succeed, not struggle. And hey, if you're driving or mid-workout, don't sweat it. Just check out the show notes for the link when you're ready. And again, that's www.ketaminestartup.com/checklist. Now let's get back to the episode.
I want to get into the kind of the nuts and bolts now, specifically like the logistics, because we have a lot of listeners who are physicians, clinicians, curious about the ketamine space, and specifically about like, how do I actually start one up? So for you, let's rewind back a bit And so you were previously you were working at an interventional pain clinic, but then now there's like the nuts and bolts of actually opening up a private practice, which we're not really taught in med school or residency or fellowship. So tell us about some of the challenges that you had faced when you were at that pivotal moment of like, yeah, you're working as an employee, but now you're going to start up your own thing.
Yes, that's a great question. Something we definitely don't learn in medical school is how to open a business, how to run a business. Yeah, I knew certain things that I had to continue to do while I added ketamine assisted therapy, for example. So there was, I still do regular pain management. My main focus is actually deprescribing opioids, trying to get patients to be open to other options and then help them wean off their opioids so that they could feel their feelings and not just take a medication to kind of numb them. So I still do regular pain management. I still recommend medical cannabis, but the ketamine assisted therapy, I knew that if I was going to open my own practice, I wanted to do it the way that I thought was most effective, which was using a multidisciplinary approach, which is something I learned from physical medicine and rehab, working with PTs and OTs and speech therapists. Instead, I was working with um, psychologists, coaches that were trained in integration and preparation. And I wanted to focus on set and setting. And I felt like in pain management, ketamine infusions were ketamine infusions, and there wasn't a lot of set and setting. And I didn't want to, um, I wanted to maximize the medicine by creating an environment that people felt safe, that they could surrender into the experience. And that really comes from the people that they're working with who are supporting them, and then the physical environment that they're in. So I have 3 office locations, and they're all set up in a way, with recliners and with music and in a very calm, relaxing way. But every single person, no matter what your diagnosis is, works with a coach or a therapist. We're preparing your mindset. We're setting intentions. We're doing integration after. We're talking about the psychosocial aspects of your life and the things that affect your quality of life and function overall. And so I knew that I wanted to continue to use that multidisciplinary approach. I also offer Spravato. So I have a psychiatric nurse practitioner that works with me, and I do that mainly because it's covered by insurance, and I wanted to treat everybody. I didn't want to treat only the ones who can afford IV ketamine, or and also I didn't want to not offer coaching for people who also couldn't afford that, because some people will say, "Well, I've already done therapy; it wasn't helpful." But this medicine is now going to create different perspectives that then have to be steered and guided in the right direction that the person can't do for themselves. And maybe they've had all the therapy in the world, but now we're actually shifting the nervous system. And a lot of what we do is nervous system regulation. So different tools to start to feel safe in their body. And so I think it's evolved over time based on the fact that I wanted to continue this multidisciplinary approach.
Yeah, thank you for sharing that. The multidisciplinary aspect is so important. When you started your private practice, was there anything logistical, or any advice you would give someone? Like you mentioned the concept of set and setting, which I think is absolutely crucial. Set referring to the patient's mindset, and then setting referring to the environment as well as the people around. And then actually, I think it's the state someone's in, like literally, are they in California state, Florida state, the United States, et cetera. Like, I think that all applies into the setting. So, some of our other clinicians and physicians we've asked, they say, oh yeah, I wish I would have done X, or I wish I would have done Y instead. Is there anything specific that you can think of that if you were to give yourself advice when you first started it, that you would have told yourself, maybe that could help another clinician in the space?
Because I offer Spravato, I would say getting on as many insurances as possible was helpful. I would also say that marketing is really important. Who do you market to? I market to therapists, I market to psychiatrists, other pain doctors, because you want to give them this outlet that you may have a patient that you have done everything you can with, but it doesn't mean that there's not other options. And I'm not competing with them because I'm not doing the interventional, I'm not doing the psych medication management. So I think marketing is important for me, getting on insurances. And the physical space is really important. That the fact that you have multiple rooms going, that they need to be quiet, the person needs to have their own experience, they need to feel safe in that environment. And I think that hiring people who understand what we're doing and how important the setting is very important too. So that everybody from the time the patient walks in, they're getting greeted in a way that makes them feel like they belong, that they are welcome, like they're not, another number, or that they're not just there for a quick follow up, but they get to know us really well. So I think all of those things are very important in setting up a practice, but I think it's the style, you have to do what's right for you. And the style for me is always to work in a team. It's always to use other people to help enhance the things that I do, and find someone who has skills that you don't have so that they could complement you. I have amazing therapists who do pain reprocessing therapy, who do a lot of somatic work, who do functional movement, and being able to hand the patient off to one of my coaches and then have the patient come back and tell me how amazing they were and how they've never done these things before, and how it's opening them to a new lens. I think that the teamwork is really very important to a successful practice.
Yeah, thanks for sharing that. So what I'm hearing is getting on as many insurance panels as possible, really consciously choosing the physical space, hiring the right people who get what you're doing, and then working in a team-based fashion are some of the crucial lessons or insights that you've had.
Yes. Well said.
What about some of the patients? What do you think patients come in with a misconception or a belief that may not be accurate? Like, what have you had to discuss and educate patients who are coming in who are like, yeah, I want to do ketamine assisted psychotherapy or ketamine infusion therapy? Like, what's the biggest misconception that they have that you've noticed that needs some education and support?
Well, I think that they think the ketamine stops their pain because it's an anesthetic. And then I have to explain to them, but you're only using it for a short period of time. So all of these changes that are happening and creating neuroplasticity are happening after the ketamine infusion.
Right.
So, for me, it's that window, that critical time after ketamine where their brain is really primed for change. So I like to prepare them properly to know, don't just come here for the ketamine, but realize that the few days or weeks after are very significant to how your nervous system can shift over time. So the preparation is important for them to understand it's the ketamine assisted therapy. It's using that neuroplastic window. And I also think that more is not better. And I learned that from medical cannabis when I'm using that with patients, and with ketamine, that, sometimes they come in and they're like, I have severe pain. I've tried every single medication. I have a high tolerance, or I've already done psychedelics. And so therefore, I want a high dose. And I try to explain to them a lot of the insight can actually be from lower doses, where they're able to quiet their mind, get into their body a little bit more. And just because you have pain and you read online that you're supposed to do a 3 to 4 hour infusion multiple days a week, there's a lack of insight when you are too sedated, or when you're in a state for too long that you can't remember. So I actually think that lower doses may be effective for people who are trying to actually heal and not just use the medicine as a pain medicine, and that there is an importance with the integration that you do after the ketamine. So, the more is not better is important to explain to them right off the bat, because they will want more. Then they have their first session and they're like, oh, wow, I couldn't have imagined what more would be. But then, of course, they build a little tolerance, they get used to that subjective experience of getting into that space, and they're able to feel more comfortable and go a little bit deeper. And I also think that the actual insight can shift them in a way that can also help their physical pain. And if we can explain that to them before, then they're looking at this as a whole mind, body, spirit type of treatment.
I think that's really important is, I mean, you're touching upon the idea of integration, right? Taking advantage of that neuroplastic window that Dr. Goldolin describes, the critical learning window. And it may not be just the ketamine or cannabis per se, but it may be that window of opportunity that shows up post infusion, post treatment that we want our patients to use. But I mean, what I've noticed is it can be hard for integration, right? Because it's just sometimes it's easier for a patient to just like lay back passively and have the experience, but then to actually go back home, and I call it doing the homework, right? Like
Right.
doing the homework is challenging.
Right. But I feel like if they don't do the homework, then again, it's sort of like giving someone the diagnosis of fibromyalgia and saying, you are now in this box. This is the label. These are your options. Giving someone ketamine and not doing the integration is basically this medicine will fix you. Just come here and get it, as opposed to go home and start to open to new ways of thinking about yourself or changing some of your beliefs or looking at your lifestyle habits, simple habits. What time do you go to sleep? Do you do any form of movement? Are you eating well? Do you socialize with others? If the foundation of your health is not strong, how are you going to have long term change? And then what I find is people think, oh, well, the ketamine didn't work, right? And then it looks like another failure. So then it becomes, well, I have all these conditions, plus I've tried all these things and it still didn't work. And a lot of times it's because we have to empower them to make those changes, which is why it's important to know who's in their environment, because sometimes they go home to someone who's not as supportive or who starts to look at them and say, oh, all of a sudden now you're going to start, reading books and doing, 5K races all of a sudden. Like, who are you? Right. So I think that when the person stops judging themselves, they start to become a little bit more open to who they truly are. And if we can get them to connect to who they are, then they feel a little bit more confident and empowered to make these lifelong changes, not just kind of using ketamine as a band-aid.
Yeah. Thank you for sharing that. I want to switch gears and ask you some fun rapid fire questions. So the first question I have for you is, if you could not be a physician at all, it has to be something outside of healthcare. What would you do instead? What do you think you see yourself doing?
So I would love to be a beach volleyball player. I don't know that I would make a good living doing that, but I would love to be outside, active. That would be like, a dream of mine. So I would love to be an athlete and compete in that way. If I had a different profession besides medicine, it's a good question. Um, yeah, I mean, that's really a bit perhaps, it's kind of in the wellness field, but I would probably do something still with, like, nutrition and the physical body, Maybe not a doctor, but, I like to help people heal, and I think that it's best when you actually live it and, kind of like you're preaching what you actually practice.
Yeah, thank you. If you could travel in time to any period, let's say you had a DeLorean from like Back to the Future and you could program it, where would you go and when would you go and why?
I would probably go to India and I would just, study with, Buddhist monks and get really in touch with spirit and spirituality and away from all the stress and pressure and just start to live a very peaceful life with very little. I'm not I don't like to accumulate a lot of things. I'm a very simple person. So I think I would just kind of go back to like the roots of just living a simple life.
Thank you. Do you have a hidden talent or hobby that most people would be surprised to learn about you? As you're thinking someone the people that have
Interesting.
asked, they'll say, "Oh yeah, I know how to play the guitar," or "I'm actually a computer programmer or software programmer." Or other people will say, "I'm actually in a band," or "Is there a hidden hobby or talent that you have that other people may not many people would know about?"
Well, I'll say, something that people don't know is that I'm an identical twin. And I think that, I think because of that, I have the ability to connect in a very deep way. And even my partner that I'm with, she's an identical twin. And I think that's a very interesting thing because I think it deepens our ability to connect. And for me, connection is so important in the world. So, I would say it's not really a talent, but it's something that I prioritize, and I love to connect deeply with people.
Thank you. I didn't know that you were an identical twin, and when the first thing I thought when I heard that is, oh yeah, all those twin studies that we learned about where they separated twins and then try to figure out what component of their health, physical, emotional, is like what component is genetic versus social. Um, but I've noticed that a lot of twins, they tell me that they're actually very quite like opposite. I don't know. I'm just curious. What are the similarities and differences between
Yeah.
you and your
Well, I
identical twin?
so my twin lives in New York, so we physically don't live close to each other, yet we talk all the time. We're very similar in certain things in the sense of how we're similar in how we relate to each other, I would say, but we are very different. Like in terms of socializing, in terms of how we discipline our kids, things like that. So I think that we started off extremely close and we are very close, but we allow each other to grow and be our own person. And so it's nice, like after years of like coming back and forth and being with each other, we give each other the space to allow each other to be themselves. We may dress differently, interested in learning about different things, but, there's always that, like, deep connection where I got your back, you got mine forever. It's just a deep love that we have for each other. But it is really interesting to have a twin because I always have that safety. I always know that someone's in my corner, that I can call someone at any time, and I think that has made me become even more successful because I have less fear, and I think that's so important for people to have a good support system.
Yeah, thank you. If let's say you knew you were going to a deserted island and somehow you could plan for it. Let's say so you're going to a deserted island. You can bring one book with you, one movie or film with you, and one type or genre of food. What would that be?
I would bring The Body Keeps the Score because I could just keep reading that over and over. I would probably bring a Adam Sandler movie because I think he's hilarious and it would keep me laughing. And food, I would say probably fruit. Just as I would say probably fruit, and at the same time, I also love pretzels. Everybody who knows me knows I love pretzels. So either, pretzels can stay around longer, but I do love fruit.
Thank you. Is there any particular type of fruit? Like for me, I'm really into mangoes. My daughter loves strawberries, tropical fruit. Is there a specific fruit that you would bring?
I actually love apples.
Mm,
Yeah.
yeah,
I
great.
love apples. I've always just grabbed an apple and I could take it anywhere and eat it anywhere. The problem is with the apples, they take too long to eat sometimes.
Yeah, they can be pretty big, especially my favorite apple is the Honey Crisp. That's like
Me
my
too.
go-to. It's just so sweet. Let's see here. What advice would you give? So this is the current version, Dr. Michelle Weiner. She's now talking to the 18-year-old version of you. What advice would the present day give to the 18-year-old self?
It's 18 years old. Okay. The advice I would give to my 18-year-old self is to follow your heart, to truly get in touch with what you love, what is meaningful, what's passionate, to feel that, and then to express that through everything, through friendships, through relationships, through work, to really follow your heart and to not allow people to and to not judge yourself in a way that allows other people to start judging you. And I think that that was such a lesson for me, to start to judge myself less and to start to love myself as I am. And I think, a big thing with being a twin is all the competition. Is, she's better than me at something, or if I'm trying to advance in something else, how does she view that? And really just to get in touch with your soul to figure out what is right for you and to judge yourself less.
Yeah, thank you. I was going to ask you about the competition side, and specifically the question was like, who's older? Because everyone's like, I was older by 3 minutes.
I'm older by 9 minutes.
So you won that one. Not that there's a
Yes.
competition. Let's see here. I think those are all the fun questions and rapid fire questions. The last question I have for you, well, two. The penultimate question is, are there any final thoughts or anything really important that we haven't discussed that you'd love to share with the audience? And then the final question will be, where can people learn more about you, your space, your clinic, and connections?
Sure. So I would just like to leave everyone with the understanding that physical pain is very complex and that a lot of neuroscience is teaching us that we can shift a different aspect of our life or our belief system that can also affect our biology. And one's perception of pain can change as they start to befriend their nervous system and feel safe and connected. And I think that in medicine, we should focus on meaning and connection so that we can have a full life. My practice is in Miami, Hollywood, and Deerfield Beach. My website is drmichelleweiner.com. And if anyone is interested in ketamine assisted therapy in South Florida, I would love to assist you with that.
Thank you so much. And we will put those links in the show notes. So if you're commuting or working out and you can't take the notes, it'll be in the show notes below. Well, thank you so much for joining. It's been an honor and pleasure getting to know you a bit better and just learning more about your style and your practice. And, one of the things that's coming up for me as we conclude is you have a really heart-forward approach, and I see you leading with your heart. And I thank you for that. I feel like the more people we have doing that, it impacts society in a way because every human being is a member of society. So when you're shining your light and you're following your heart, Michelle, you allow others to do the same.
Thank you. Thank you so much. I think it's nice that we allow each other to heal. And thank you for bringing me on today.
Thanks for joining us for this inspiring conversation with Dr. Michelle Weiner. Her insights about reframing fibromyalgia as central sensitization, incorporating spiritual dimensions into treatment, and using ketamine as a catalyst for deeper healing offer valuable perspectives for any provider working with chronic pain patients. If you found this episode valuable, we'd really appreciate it if you could leave us a review on Apple Podcasts or Spotify. This will help other entrepreneurial medical professionals discover these important conversations and grow our community. For complete show notes, including links to Dr. Weiner's practice and resources mentioned, visit ketaminestartup.com/podcast. And again, remember, this podcast is for educational purposes only and doesn't constitute medical or legal advice. The approaches discussed reflect individual provider experiences and should be evaluated with your own practice context and regulatory environment. Thanks again for listening to the Ketamine Startup Podcast, and we'll see you in the next episode.